followers of Neuro Takeaway, welcome back to the channel. Today we're going to talk about Chiari I. As you know, this is a low position of the cerebellar amygdala that protrude through the foramen magnum. It is a very frequent finding. It happens in around 1 to 3% of the population, especially in young people and children. And it has an asymptomatic course in around 50% of cases. When symptomatic, Chiari I may be associated with several manifestations. We can divide them in 3 big groups. One is headache, which is very frequent. It is of short duration, usually less than 5 minutes, and it happens especially in the posterior part of the head and the cervical region. And it can be exacerbated by Valsalva maneuvers as sneezing or coughing. The second group has to do with the compromise of the cerebellar and the brainstem, as dizziness, tinnitus, vertigo, diplopia, imbalance, and ataxia. And the third group has to do with progressive hydrosyringomyelia. We can have scoliosis, progressive scoliosis, we can have numbness, paresthesias, pain, and disorders of sensitive disorders in general. And there are 2 very dangerous symptoms, especially in children, choking and sleep apneas, that can produce the death of the patient. In 1891, Professor Hans von Chiari, an Austrian neuropathologist, described for the first time this entity as a caudal extension of the hindbrain into the cervical canal in a group of patients with hydrocephalus. He never spoke about a malformation. The concept of this disorder as a malformation came from a paper written years later by 2 students of Arnold, a German professor, Professor Gredig and Schwab, who written that the disorder described by Arnold, which was another alteration of the posterior fossa in relation with myelomeningocele, was a malformation related with Chiari alteration. And they extended the concept of a malformation to the first description of Chiari. So this misname is very important and has produced a lot of impact in the family, the patients, the prognosis, etc. So now there is a revision of this entity. The name is changing. There are several options, and one of the leaders of this critique is Professor Concetio Di Rocco, who is a famous neurosurgeon. He is now the chief of the pediatric neurosurgery division at Hanover, Germany. He works in the International Institute of Neuroscience there. And basically what he says is that this Chiari I is a functional state secondary to an alteration between the intracranial and the spinal canal pressure gradient. This can be due to several disorders. Certainly, some of them can be genetic, but in most cases, we as neuroradiologists have the job to look for this primary etiology that can be treated differently according to the physiopathological process that finally, eventually lead to this Chiari I anomaly. Well, here we have a typical case of Chiari I. You know that MRI is the study of choice because of its high anatomical resolution. And you can see here the caudal extension of the amygdala through the foramen magnum into the cervical canal. We have to keep in mind 2 concepts. One, if the measurement of this extension, it is in general considered that 5 or more millimeters is abnormal below the McRae line, which goes from the bastion to the opistheum. The other concept is the shape, A peg-shaped protrusion is more aggressive and symptomatic than a blunt protrusion. We have to look for the CSF spaces around the amygdala and around the brainstem, especially in the anterior and posterior aspects of these structures. And we can use for these T2 volume slices of 1 millimeters or less, or the CSF study, flow study. But as you know, this technique is difficult. It is associated with technical troubles, so we prefer to use the thin T2 slices. And finally, MRI is sensitive for detecting hydrosyringomyelia. You can see in this case a cervical dorsal cavity. This cavity is usually located in the cervical region, but sometimes it can be huge and extended all the way down to the conus. Here you can see some alterations of the posterior fossa that we have to be aware of because they can be associated with the Chiari I. At the top on the left, you can see the posterior fossa pentagon. Sometimes it's useful to draw these lines because, as in this case, we can find that one of them is smaller than the rest. In this case, the clival line is smaller, so this is a case of clival hypoplasia. At the bottom on the left, you can see the elongation and caudal implantation of the medulla with a bulbomedullary kinking at the level of C2. At the top on the right, you can see the retroflexion of the dens, which is defined when the dens is located more than 9 millimeters behind the line that goes from the clivus to the inferior posterior part of C2. And finally, at the bottom on the right, you can see the coexistence of two anomalies. One is basilar impression, which is defined when the tip of the dens is located more than 3 millimeters above the line of Chamberlain, which goes from the hard palate to the opistheon. And the other one is the reduction of the angle formed between the clivus and the posterior aspect of C2. When this angle is below 125 degrees, we are in the presence of this clival kyphosis. And these alterations are not merely descriptive, they are very important because they can produce different approaches regarding the surgical treatment. On top of looking at the posterior fossa, its metrics, its morphology, it's very important to examine the calvarium in every patient with Chiari I anomaly, because there are several etiologies, several causes that can produce hypertension of the intracranial compartment. One of the most frequent is craniosynostosis, especially when it is multiple. Here you have two patients. On the left, a patient with Apert syndrome, which, as Poisson syndrome or Pfeiffer or others, can generate through the craniosynostosis an increase in the intracranial compartment with regard to the intracanal compartment. So they produce the descent of the cerebellar amygdala. On the right, you can see another patient with an acquired craniosynostosis, in this case a patient with rickety from Garrahan Hospital, and it's very frequent in these cases to have craniosynostosis, to have an abnormal shape of the cranium, the posterior fossa, convexobasia, and a descent of the cerebellar amygdala. Well, and in every case of syndromic craniosynostosis, it's very important to look at the veins. As we said, these patients can have venous hypertension secondary to stenosis of the skull base foramen, especially the jugular foramina. So they develop collateral circulation, and as we can see in this case, this collateral circulation may be located at the subcutaneous tissue of the back of the neck. In this case, there are flow voids in this region, and they turn out to be dilated veins on venography. So, as you can imagine, it's of paramount importance to alert the neurosurgeon about this finding so they don't take them by surprise. In addition to look at the calvarium, the posterior fossa, we should look at the ventricles. Not just hydrocephalus may be associated with Chiari I, but some disorders secondary to malfunction of ventricular catheter can result in the same disorder. For example, an overdrainage of hydrocephalus can lead to enlargement of the calvarium with intracranial hypertension, or, as in this case, a slit ventricle syndrome can be associated with intracranial hypertension and Chiari I. Here we can see the importance of looking up at the brain, at the cranium, in every patient with Chiari I. On the left, we see a patient with an MRI study of the cervical and dorsal spine, which shows very nicely the Chiari I anomaly. But if we see at the brain, we can detect the etiology of this anomaly, which is a cerebellar tumor, a medulloblastoma of the group 3, associated with hydrocephalus. On the right, we have another very interesting case of an arachnoidal cyst located at the level of the supravermial cistern, which produces downward displacement of the cerebellar, blockage of the subarachnoid spaces at the level of the foramen magnum, and a very severe hydrosyringomyelia. Even though it's very rare, the spontaneous resolution of Chiari I anomaly has been very well documented, both in children and adults. This was a teenager who, on consecutive MRI studies, has shown the complete resolution of this anomaly between 2008 and 2017. It's not clear what is the etiology of this evolution, but it is without any doubt a warning for the neurosurgeons regarding the urgency of the indication of the resolution, the surgical resolution of this problem. And this is a nice case to illustrate the pathophysiological mechanisms that, whatever the etiology, the primary cause, will lead to the same consequence. This is like a sequence of events that ends up with the Chiari I anomaly. In this case, you can see in the upper row hydrocephalus, non-communicating hydrocephalus secondary to obstruction of the outlet foramina of the fourth ventricle. You can see on the axial images the diverticula at the level of the foramina of Luschka. They are called sometimes the mouse ear sign. This case was associated with Chiari I anomaly and with edema, very huge edema at the level of the spinal cord. This patient received a third ventriculostomy, and 2 weeks later he showed a complete resolution of the hydrocephalus, the regression of the Chiari I anomaly, and the regression of the presynex state at the level of the spinal cord. And here we have two cases of what we can call Chiari I mimics, because they are patients with symptoms very similar to those produced by Chiari I anomaly, but without the presence of cerebellar ectopia. On the left, a case from Meilan Ho. This is a Blake pouch cyst that protrudes into the cisterna magna and into the posterior superior subarachnoid space of the cervical spine, which did very well after the communication, the surgical communication of the cyst. As you know, this structure, the Blake pouch, is a normal structure during embryology that fenestrates spontaneously and allowing the communication of the fourth ventricle with the subarachnoid space. On the right, a case from Garrahan Hospital. This again was a patient with symptoms very similar to Chiari I, but the obstruction of the foramen magnum was due to an arachnoid cyst at this level. The patient did very well with surgery. And these two cases lead me to the concept of Chiari zero. Chiari zero is an entity proposed by Tubbs and et al. Many years ago, the group from Alabama. And basically, this entity refers to a patient with symptoms of Chiari I with hydrosyringomyelia, but without cerebellar ectopia. Many of these patients did very well after the decompression of the posterior fossa. And in some of them, the neurosurgeons could detect a very thin veil covering the fourth ventricle. So maybe if we use the appropriate sequence, the volumetric T2 sequence with very thin slices, we can detect these membranes and we can help the neurosurgeons with this diagnosis. And regarding the surgery of Chiari I, it is a relatively simple surgery in experienced hands. There are several techniques that go from craniectomy to craniectomy plus duroplasty, and finally craniectomy, duroplasty, and thermocoagulation of the tonsils. In rare instances, there is a need for occipital-cervical fixation or an anterior approach. The complications are the usual for any surgery, but in this case there is one complication very specific for Chiari, which is the drop of the cerebellum because of a too big craniectomy of the occipital bone. In this case, you have an example of this complication. The first two photos on the upper row show the typical Chiari I anomaly. The third one is the post-op. You can see the dropping of the cerebellum with the blockade of the cisterna magna. On the CSF flow sequence, you can see there is more alteration in the post-op than in the pre-op state, and there is more hydrosyringomyelia. Well, to wrap up, I would like to say two things about CT scan and Chiari I. The first one is that CT is very useful to rule out this diagnosis with the sagittal reconstructions of the multi-slice CT. So if the doubt of the clinician is this diagnosis, there is no need for an MR. And the second point is that if the CT was asked before a lumbar tap in order to rule out any mass lesions, it's very important for us to look at the cisterna magna in order to diagnose a Chiari I, because if we find this anomaly, we should alert the clinicians because they may change the indication or maybe the technique of the procedure. And with this, I would like to thank you for watching the video, and I hope we can see you again next week. Bye-bye.